this is Handsome Nerd ASMR, back with another video. Today we are going to be covering the pharmacology of diabetes mellitus, or in other words, the medications that are appropriate for treating patients with diabetes mellitus types 1 or 2. Before we begin, let's talk about what diabetes is. Diabetes encompasses a group of metabolic disorders that are marked by chronic hyperglycemia or increased or elevated blood sugar level due to the impaired insulin secretion, insulin action, or even both. It includes the following. We have 2 types of diabetes mellitus. Type 1 diabetes mellitus. This involves autoimmune destruction of pancreatic beta cells, leading to absolute insulin deficiency. We also have type 2 diabetes mellitus. This time there is resistance to insulin and relative insulin deficiency. During pregnancy, we can also have gestational diabetes mellitus, where there is glucose intolerance that occurs during pregnancy. We also have pre-diabetes, where that involves elevated fasting blood glucose, but that does not reach the diabetic range of the blood sugar level. Typically, pre-diabetes blood glucose level should be between 100 to 225 milligrams over deciliters. Here is a table showing the fasting plasma glucose concentration in the blood in normal situations for patients with pre-diabetes and for patients with diabetes. We also have the A1C percentage, also known as hemoglobin A1C. Alright, let's move on to talk about diabetes insipidus. So, unlike diabetes mellitus, diabetes insipidus involves the antidiuretic hormone, or ADH. First, we have central diabetes insipidus, which involves the deficiency of antidiuretic hormone production, also known as vasopressin. In contrast, nephrogenic diabetes insipidus pertains to renal insensitivity to antidiuretic hormone, where your kidneys fail to respond to the presence of antidiuretic hormone and ultimately reabsorb water from the urine. So, the symptoms of these, or the symptoms of diabetes insipidus, can include polyuria, polydipsia, with no glucose dysregulation. Let's talk about the complications of diabetes. In general, chronic hyperglycemia can lead to the following. For macrovascular complications, this can involve heart disease or stroke. For microvascular complications, this can involve retinopathy, nephropathy, and neuropathy. Other complications can include skin infections, delayed wound healing, and erectile dysfunction. With these principles in mind, we can come up with treatment goals. For type 1 diabetes mellitus, the treatment goal should be to replace insulin in order to maintain euglycemia. For type 2 diabetes mellitus, the treatment goal should be to enhance insulin sensitivity, promote insulin secretion, or reduce glucose absorption or reabsorption. The body makes insulin, but can no longer use it appropriately to keep blood glucose levels normal. And that is why we need to enhance insulin sensitivity in type 2 diabetes mellitus situations. In other words, the goal of the treatment is to help the body utilize native insulin efficiently in order to keep the blood glucose levels normal, or alternatively to help the body eliminate excess glucose. Now, in some cases, we may also need to administer medications that are crucial for patients with both type 1 and type 2 diabetes mellitus. So, for these patients, the clinician needs to emphasize the importance of proper diet, weight control, and physical activity. In the meantime, let's dig into some anti-diabetic drug classes that are out there. The first class we have is called insulin and insulin analogs. These classes of drugs can be administered subcutaneously, which is the most common route of administration. Alternatively, we can utilize intramuscular or intravenous injection of the drugs in cases of emergencies. This is typically the case for patients who present to the emergency department with diabetic ketoacidosis. Inhalation can be another way to absorb or to administer these insulin or insulin analog drugs. And there are various types of these drugs. So we have rapid-acting insulin analogs, such as insulin lispro. We have short-acting insulin, such as regular insulin. We have intermediate-acting insulin, such as NPH insulin. And most importantly, we have long-acting insulin analogs, such as insulin detamir, where the brand name is known as Levemir. So, the key points are that these drugs or insulin analogs must bypass gastrointestinal tract by being administered parenterally, because it would be destroyed orally through the gastrointestinal tract. So, we should not utilize oral administration of these drugs. Also, insulin is absorbed readily, but can be eliminated quickly. And so, soluble insulin produces rapid and short-lived effect, and thus wide fluctuations in the blood glucose may occur as a result. Now, we talked about the long-acting form of insulin, like the insulin detamir, and this actually utilizes modifications such as albumin binding in order to slow the release and ultimately prolong the proper function of the insulin. So that is the first class of drugs. The second class of drugs consists of amylinomimetics. One classic drug is the pramlintide, and the brand name is Simlin-Pen. And so the mechanism of the amylinomimetics is to mimic amylin. And specifically, it will delay gastric emptying, suppress glucagon release, and ultimately reduce appetite. It can be used in an adjunct fashion in type 1 and type 2 diabetes mellitus. So it can be used in both cases of diabetes mellitus, type 1 and type 2. So that is the amylinomimetics. And remember, pramlintide is the drug that is in amylinomimetics. Once again, it delays gastric emptying, suppresses glucagon, and reduces appetite. Let's remember that. Alright, now we go into some of the more common diabetes drugs out there. So, another class is called biguanides. And the prima donna drug that is a biguanide is your metformin. So metformin, what does it do? We've heard a lot about this drug in society and probably in your television advertisements. But let's talk about what it actually does. So it actually increases the GLUT4 activity in the muscle and fat, the fat cells. So GLUT4 is a specific type of glucose transporter from the extracellular space into the cell. In other words, it helps these muscle and fat cells to take up glucose, which it can utilize for energy. choice. We also have another class called sulfonylureas, and so some examples of these include a glyburide and glipizide. How does sulfonylureas work? Well, it closes the potassium ATP channels in your beta cells of the pancreas. This then leads to the depolarization of the cell, which then leads to the calcium influx and then ultimately the insulin release. And it specifically promotes insulin release by binding to the sulfonylurea subunit, or SUR1, of the SUR1/KIR 6.2 APT sensitive potassium channel, as shown over here. You don't have to know this exact detail unless you're curious about it, but basically the end result is that the channel conductance is inhibited and ultimately the membrane is depolarized, which leads to more insulin release. And this specifically occurs in the beta cells of the pancreas where insulin is produced. So all you really need to know about sulfonylureas is that it targets the beta cells, specifically the potassium ATP channels. There's depolarization and calcium influx, and then the end result is insulin release, which can then be utilized to lower blood glucose level. Some adverse or side effects can include hypoglycemia, weight gain, and for patients who are allergic to sulfa or Bactrim sulfa, sulfonylurea should be avoided. So that's something important to consider. Alright, so let's move on to another class of diabetic drugs, or drugs to treat diabetes. The next class is called meglitinides, and some of these include the ripeglinide and the neteglinide. So meglitinides act similarly to sulfonylureas, but they happen to bind to different sites, and the duration of action for these drugs are shorter compared to sulfonylureas. They should be used, or they can be used for postprandial glucose control, or after a patient eats a meal and they want to control their blood sugar, these meglitinides can be used. Alright, let's move on to another class. The class is called thiazolidinediones. I hope I pronounced that correctly. But anyways, these classes of drugs include rosiglitazone and pioglitazone. The mechanism of action for these drugs is to activate the PPAR gamma, which then leads to increased insulin sensitivity. And so the increased insulin sensitivity can then help to counter the decreased insulin sensitivity seen in type 2 diabetes patients. However, there are some major risks of weight gain, heart failure, and thus they are not considered first-line treatments for treating diabetes. So that's about it for thiazolidinediones. And we have another class called alpha-glucosidase inhibitors. So what are alpha-glucosidase inhibitors? Well, some medications include acarbose or meglitol. Their mechanism of action is to delay carbohydrate digestion in the intestine, thus slowing glucose absorption. That is why they are useful for postprandial or after meal glucose control. They are also often adjunctive. So that is the alpha-glucosidase inhibitors. And remember, they include the acarbose and meglitol. Next we have the DPP4 inhibitors. This is another important class of drugs because they include the following medications: sitagliptin, saxagliptin. What happens with the DPP-4 inhibitors is that they inhibit breakdown of incretins, which leads to increased production and release of insulin and decreased production and release of glucagon. And I actually have a nice flow chart up here showing how DPP-4 inhibitors work. So, what does this inhibitor do? Well, it blocks the DPP-4 enzyme. And so, normally, the DPP-4 enzyme inactivates the incretins. And the incretins will normally be responsible for stimulating insulin release and inhibiting the glucagon release, where the net effect of this is the lowering of blood glucose. However, if DPP-4 enzyme is activated, it's going to inhibit the incretins, and what's going to happen is you're going to have increased blood glucose level. So, the primary objective of the DPP-4 inhibitor is to inhibit the function of the DPP-4 enzyme. And so, when you inhibit the DPP-4 enzyme, because it normally facilitates increased blood glucose level, inhibiting the DPP-4 enzyme will lead to the lowering of the blood glucose, because now the incretin can't carry out its function instead of being inhibited. And some incretins include the glucagon-like peptide 1 and the GIP. We'll talk more about the glucagon-like peptide 1 later. But anyways, that's the basic mechanism of how DPP-4 inhibitors work. Once again, remember that they consist of sitagliptin and saxagliptins. Okay, the next class of drugs we have is glucagon-like peptide 1 receptor agonists. Alright, this is where the fun begins. We have some classic drugs like exenatide, liraglutide, and most importantly, semaglutide. You probably recognize the brand names of these drugs like Ozempic or Wegovy. Well, now you know that it is a semaglutide. And now you're about to learn how they actually work. So, interestingly enough, these drugs are known as incretin mimetics. And what's going to happen is, by copying the incretin function, they're going to promote delayed gastric emptying, and they're going to also enhance the insulin secretion. We just talked about earlier the function of the incretins, what their basic mechanism is, which is to ultimately lower blood glucose. The semaglutide, or your typical Ozempic or Wegovy, is copying this thing right here. So just remember that. Now, the benefits of the GLP-1 receptor agonist is that it induces weight loss, but there needs to be, or it may be contraindicated for patients with pancreatitis risk. So some caution needs to be noted for patients who may present with some pancreatitis risk. Alright, let's move on to another class. This time, let's talk about the sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors. These drugs include canagliflozin and dapagliflozin. Basically, a lot of drugs that end with the suffix flozins. So the mechanisms of the SGLT2 inhibitors is to block the renal glucose reabsorption that happens in the proximal convoluted tubuli of the nephron. This will lead to increased urinary glucose excretion. And so, when the patient who is taking these drugs undergoes a urinalysis, don't be surprised by the increased level of urine glucose. Now, the risks associated with these drugs include increased susceptibility to urinary tract infections, also dehydration and hypotension. So watch out for these possible side effects. And then of course we have some other types of diabetic drugs out there, such as colesevelam. These are known as bioacid sequestrant, but the mechanism as to how they lower the glucose level in the blood is still unclear. Hopefully we learn more about it someday. also have dopamine agonists like bromocriptine. These may somehow reset the hypothalamic regulation of metabolism. Mechanism is still unclear, but at least you know that a bromocriptine is a dopamine agonist that can somehow be used to treat diabetes. We also have hypoglycemia antidotes, so in situations where patients have lower than normal blood glucose level. First, we have the classic glucagon, or the brand name glucogen. This will raise the blood glucose level, and it can be administered subcutaneously, intramuscularly, or intravenously. We also have octreotide, which is a somatostatin analog. And somatostatin is one of the several hormones produced and released by the body. But anyways, it blocks excessive insulin effects, such as in cases of sulfonylurea overdose. We talked about earlier how sulfonylurea is responsible for lowering the blood glucose level, but too much of that can lead to much lower than normal blood sugar level, so that's when octreotide comes in. Finally, we have dextrose, which is basically an intravenous glucose source. In other words, a straightforward way to administer more glucose into the patient's bloodstream. Now we can talk about some immunomodulatory therapy for patients with type 1 diabetes mellitus. So first we have teplizumab, or also known as TZIELD. It is basically an anti-CD3 monoclonal antibody. What it does is that it preserves the beta cell function early in the type 1 diabetes mellitus by inducing T cell anergy or apoptosis. Basically, it provides a protective function for the pancreatic beta cells. The potential side effects of this, however, can include lymphopenia, rash, and cytokine storm-like effects because we are modulating the immune system. And then there's some classic devices for managing diabetes or blood sugar level. You may have encountered some of these already, but let's just go over them. So they include glucose monitoring devices like finger stick meters and continuous glucose monitors like Dexcom G6. We also have insulin delivery mechanisms like the insulin pumps or even inhaled insulin devices or modalities. Pumps can include Medtronic or Omnipod 5, and inhaled insulin can be utilized in a supplemental manner. So we talked about all of the different classes of diabetes or drugs for treating diabetes, and also some devices that can be used for monitoring blood sugar level. As long as you're able to distinguish between diabetes mellitus and diabetes insipidus, you should be good to go to compare the differences between type 1 and type 2 diabetes along with the appropriate treatment goals. And when considering treatment goals, it is important to recognize the unique or specific diabetes complications that can arise along with risk factors for the specific treatments. And it is also important to have a solid understanding of the mechanisms and uses of the major anti-diabetic drugs that we talked about. And then, while it is easy to focus on the goal of reducing blood sugar level in patients with some form of diabetes, it is also to keep in mind situations where hypoglycemia can result, and this leads to an importance of understanding proper hypoglycemia management that we talked about earlier, and then some other new and evolving therapies for treating type 1 diabetes mellitus. That is it for today's video. I hope you learned a lot from this ASMR style lecture. Feel free to like and subscribe if you want more videos like this.